Well, we heard the reason we're here. This is more important than any data. But the data gives us an opportunity to look and see where we can do better. This is going to be on LDL management, the trends 2020 to 2022 from the Family Heart Database. Now, we know that when we look at this database, we're looking at one of the largest collaborative efforts to see exactly what's going on in the United States, specifically related to LDL management and also lipoprotein little a. You'll hear more about that later. It's a non-interventional retrospective cohort study. And this particular subgroup that I'm going to discuss with you are patients with ASCVD. We're going to look at the LDL lowering medications, whether it be monotherapy, combination therapy, unfortunately, no therapy. We'll also look at the duration of therapy. Simply electronic prescribing of a medication doesn't mean the patient's going to take it. We'll also discuss LDL goal attainment. I'll look at two levels, less than 70 and less than 55. And then, because disparities in the United States are so persistent and distressing, we looked at our data across age, sex, race, ethnicity, household income, and education, which are the social determinants of health where people work, live, play, and pray. You're going to hear more going forward today about the Family Heart Database. It's de-identified data, medical claims, lab data. This particular set is going to be from 2021 to 2022. On the right-hand side, you can see the size, the millions of people who are included in the Family Heart Database. The subgroup that I'm going to discuss is 3,440,000 plus patients. These are adults diagnosed with ASCVD, at least one prescription claim, something was written, and one LDL at least measured. Our definition of ASCVD is quite broad. It includes patients who've had myocardial infarction, various interventions, angioplasty, bypass, angina, patients with stroke, peripheral vascular disease, or any type of ASCVD. In terms of duration, we're going to look across the 2021 to 2022 period. And in terms of types of therapy, if there's any overlap in any particular therapy, we'll consider that combination therapy. This is a hierarchy of those drugs which more intensively lower LDL. At the top, you see PCSK9 inhibitors plus statins. Of course, statin high-intensity monotherapy is concordant with the 2018 ACCHA guidelines. The United States is a little slow in how we promulgate guidelines. Our last guideline suggests that high-intensity monotherapy was an appropriate way of treating patients with ASCVD. At the bottom in the red, unfortunately, in patients who have documented disease, I'll show you that some of the patients had no LDL lowering therapy during the entire period. If you look at the cohort in terms of demographics, of course, this is an older population, half female. Racial and ethnic diversity is good, but both the mean and median LDLs were suboptimal. In terms of the social determinants of health, we're going to look at household income, education, and at the bottom you look at payer. Only a small percentage of these patients had no insurance at all. So perhaps it will show that if we have access, we can blunt some of these social determinants of health and their impact on ASCVD. Here's the data. In the pie, in terms of LDL lowering drugs, the more intense combination therapy was only used in 6.6%. That's in the light blue. The maroon are patients who, unfortunately, over 30%, no therapy, despite a broad definition of ASCVD. On the right-hand side, you see the duration of lipid-lowering therapy across the 24 months. In the yellow are persons who only had documented treatment for 12 months or less. Again, in the maroon, 30.3% of patients with documented ASCVD by claims, no lipid lowering therapy. Now let's look at intensity. If you would assume that PCSK9 inhibition, along with other medications, is the most intense form of LDL reduction, it was used in the pink and yellow in less than 2% of the patients. Going back to monotherapy, 30% of patients had high-intensity monotherapy. You can make the case that that still is concordant with the ACCHA Multi-Society 2018 guidelines. However, the optimal therapy of combination therapy and more intense therapy was used in less than 2% of the patients. And inappropriate therapy, either low to moderate intensity statin therapy or nothing at all, in 61% of the patients. What about goal attainment? In the Carolina blue, you see that 61% of the patients, I'm from New Orleans, I'm not from Carolina. 61% of the patients never achieved an LDL of less than 70. This cartoon we designed to show what would happen if you had 100 Americans who reflected on these data. The dark figures would be 13 out of 100. Those are the patients who had the appropriate either high-intensity monotherapy or combination therapy for the entire 21 to 24 months. 13 out of 100 with appropriate therapy. Let's look at the social determinants of health. I put a circle around those that are described as having an LDL less than 55, and then on the right-hand side, those who did not. You had lower levels of LDL attainment in younger people. Mark Twain said, "Youth is wasted on the young." Women, less intense therapy, and those who identified as Black, less intense therapy. On the right-hand side, that translates to more of those particular groups having LDLs which are greater than 70. Younger, women, and Black individuals. Then if you look at the social determinants of health, which we know are powerful predictors of not only coronary disease, but overall ASCVD and mortality, the differences in terms of LDL goal attainment were actually blunted, and this is because most of these patients had some form of access, speaking to the need for perhaps universal health care in the United States. In terms of adherence, some of the similar trends that we saw: younger people, women, and in those who had LDLs greater than 70, younger people, women, and Black individuals. So if a person had no lipid-lowering therapy in this particular cohort, you could be predicted to be younger and female, and if you were less likely to adhere throughout the entire terms of the cohort, you were more likely to be younger, female, or identified as Black. In terms of adherence, it's blunted, again, showing that these powerful social determinants of health can be benefited by having access. So what do we get from these data? This is a snapshot. We need to accumulate data going forward, and we will. But thus far, it shows a lack of urgency to manage LDL-C and follow US recommendations, either high-intensity monotherapy or combination therapy, in patients who have a broad range of ASCVD high-risk status. Unfortunately, unbelievably, 61% of these ASCVD patients did not achieve an LDL less than 70. It was worse in younger persons, women, and Black individuals. And remember the cartoon, only 13 out of 100, 12.7%, had guideline-directed medical therapy for the entire 21 to 24-month period. This concludes that although we developed new drugs and new therapies, and we saw the history of that development yesterday, these innovative therapies are not being utilized across the population, including combination therapy, and even high-intensity monotherapy is underutilized. Throughout 2021 to 2022, most individuals inappropriately received low to moderate intensity therapy, and most distressingly, 30% received nothing at all. Thank you.